My name is Dave Dickman. I'm a comprehensive ophthalmologist. I have a practice right outside of Raleigh, North Carolina. I opened my practice in January of 2012, and I'll be sharing some thoughts about the business of ophthalmology and the Iridex IQ 532 and why it's of benefit to the business of ophthalmology. Some important background information. Most of us are not good business people. We're just not. Part of that is just our personalities, part of that is our training. We're all intelligent enough and did well enough in school. We could have gone to business school, we all could have been Wall Street bankers. But we decided that we wanted something where we could not only earn a good living, but also help people. We're kind of halfway in between Wall Street banker and Peace Corps volunteer. Our training, unfortunately, for the most part, focuses on the clinical aspects of medicine, and in the past that's been enough. But as the pressures of decreasing reimbursements, increasing litigation, and increasing overhead affects what we take home, we need to adapt. As you can see here, the average salary has dropped over the last 20 to 30 years precipitously. Part of that is that taking care of patients just costs a lot more than it did 20 or 30 years ago. There was an article in the Review of Ophthalmology in 2008 that profiled several physicians who opened their own practice, one of whom did so back in 1989. At that time, he took out a loan for $30,000 to open his practice. When I opened my practice 20 months ago, that number was just over $300,000. Now, by the Academy Preferred Practice Patterns, we can't even properly take care of our plaquenil patients without either fundus autofluorescence or a $60,000 OCT. So that's one instrument for twice the cost of opening an entire practice 24 years ago. So we have to be very wise in what equipment we purchase and the decisions that we make. That doctor back in 1989 helped support himself and pay back that loan by assisting on cataract surgeries, and he was reimbursed in today's dollars, $1,400 per case. Now we get about $700 per case as the primary surgeon. You're not even allowed to have an assistant. So when I opened my practice, one of the only pieces of new equipment that I purchased was this, the IQ 532. And I think that besides the slit lamp, it's probably the most useful piece of equipment for both my patients and my business. It's a potential benefit to my diabetics, my glaucoma patients, central serous patients, high myopes, and others. Here's a brief list of procedures that we can perform with that one laser. So what's so special about the IQ 532? Essentially Micropulse. Micropulse refers to a technology whereby each of your laser shots is broken down into multiple spaced, repetitive, brief pulses of laser. This allows lower laser energy per pulse and cooling of the target tissue between the pulses. Why do we want to do this? Because we can achieve equivalent or superior outcomes without inducing tissue damage. The micropulses are above the threshold of biochemical effect, but they're below the threshold of a visible destructive lesion. So with this, the tissue is stimulated to produce a stress response, and beneficial biochemical factors are upregulated. This is a representation of the damage and benefit of the various types of laser treatment. Essentially, with the traditional laser, we're burning large areas and we're gaining small surrounding areas that contribute to the therapeutic effect. With the micropulse, there's no actual burn, and the only limit to the amount of tissue contributing to the therapeutic effect is how much tissue you lase. So here we see an OCT done after a continuous wave pattern scanning subthreshold laser on the left-hand side and micropulse on the right-hand side. What we see here is that there's anatomic damage on the left-hand side and no anatomic damage from the laser on the right-hand side. So subthreshold laser doesn't necessarily mean micropulse. Conventional laser can be applied in a subthreshold fashion using lower energy, but it's not the same as dividing the laser into micropulses. Micropulse divided laser energy heats the tissues less than a continuous pulse, even if the total amount of energy is the same. So let's take micropulse trabeculoplasty as an example of how we can put the IQ 532 to good use for the benefit of our patients, our practice, and even the healthcare system as a whole. Glaucoma medications are expensive. Average cost ranges from $160 to $743 per year. Yearly cost of prostaglandins is about $475, which when I'm using medication as my initial therapy, that's typically what I use. That's well more expensive than even if you did a micropulse treatment yearly, and it doesn't take into account the value of your patient's time and effort obtaining and using the prescriptions, your time writing the prescriptions, dealing with your buggy e-prescribing system, and talking to pharmacists on the phone. It also leaves compliance in the hand of your patients who may or may not be equipped to deal with that. So here's an example illustrating this over just a 25 patient sample size. So if we treat 25 with laser, even if we assume that 20 of them respond and 5 don't, we've cost the healthcare system $10,250. $78.75 of that goes to our practice for the micropulse treatment. In year 2, assuming that those 20 responders are still responding, then the cost to the healthcare system is just $23.75, which is the cost of prostaglandins for them. If we hadn't done micropulse in anyone, then the cost to the healthcare system is the cost of prostaglandins in all 25 patients every single year. So over a 2-year period, doing micropulse trabeculoplasty in just 25 patients, we're saving the healthcare system over $10,000, and we're also saving our patients some out-of-pocket expenses. So who do you offer it to? Basically anybody who doesn't have a contraindication. The main ones being uveitic or traumatic glaucoma, or somebody whose glaucoma is so advanced that a transient pressure spike will snuff out their nerve, although I've never actually seen a pressure spike after MLT. I don't talk my patients into having the laser done. I just try to explain to them the risks and benefits of the laser versus medication. And essentially it comes down to perceived risk of the laser versus the hassle and expense of taking a medication. And I actually use myself and my mother as examples of a very strong family history of glaucoma. My mom's been taking a prostaglandin for about 10 years. She takes 1 drop at bedtime, and that's fine. But she's somebody who's very compliant, who has a good prescription plan, who doesn't have a lot of systemic medications, and she'll do great with that. I'm a horrendous patient. I can't even remember to take vitamins every day. I'm certainly not going to remember to take a glaucoma drop every night for the rest of my life. It's just not going to happen. So I also always ask patients about their copays. Knowing whether or not a patient has a $50 copay for medication or a $5 copay for medication should absolutely be weighing into your treatment decisions. If their copay is that high, they're just not going to be compliant. They're going to try to stretch out their medications. They may not get it at all. It's just not going to happen. So what do you expect from doing micropulse? Between a 20 and 30% pressure drop is about what you should expect, and that's somewhat related to the energy that we deliver. When I first started doing the procedure, it was around 700 milliwatts, and we were getting somewhere around 20%. Now it's closer to 1,000 milliwatts, but that depends on the patient and the situation. Here's our parameters. It's a 300 micron spot size. It's nice and big, more like SLT than ALT, so it makes it a bit of an easier procedure to do. Our duration is 300 milliseconds, and again, somewhere around 1,000 milliwatts. Glaucoma patients who are already on more than 1 medication without good pressure control are good candidates for laser treatment, and that's the situation with the patient that I described here. This is a lady who was sent to me from a retina colleague for management of glaucoma on both sides and cataract on the right side. She has dry macular degeneration on the right, she has wet on the left, she has a cataract on the right, pseudophakia on the left, she has status post Eylea injections on the left, and pucker surgery on the left. Her vision was 20/40 minus on the right side, 2400 eccentrically on the left side. Angles were open, cornea is mildly thick, pressures in the low 20s on 3 medications. She was on dorzolamide 3 times a day just on the left side, Istalol in the mornings on both sides, and Zalatan at bedtime on both sides. So here's somebody who's on plenty of systemic medications, she has multiple eye problems, and she's on a complicated medication regimen for her glaucoma. I felt that pressures of 22 and 21 were just too high for someone on 3 medications, and I suspected problems with compliance. So initially, I asked her to change to COSOP twice a day on both sides and Zalatan at bedtime on both sides to try to simplify her regimen and maximize compliance. And I asked her to come back in a week to reevaluate, which is quite a bit sooner than I normally would recheck somebody after a medication change. But in someone like her who's got glaucoma eating away at her peripheral vision and she's got macular degeneration affecting the central vision, I was pretty worried about this lady. At the 1 week follow-up, we did testing. Field showed superior nerve fiber bundle defects on both sides. HRT3 showed low rim volume and area and thinning on the right side of the rim. Borderline cup shape measure on the right and high cup shape measure on the left. Pressures were actually great at that visit, 12 on both sides. However, she's taking all of her medications 3 times a day at that visit, and she's still using the old medications. She hadn't switched to COSOP. So clearly for this lady, just changing around her medications and simplifying things for her is not going to do it. So we decided to proceed with the laser in hopes of stabilizing her pressures in the 14 to 16 millimeters of mercury range, and then perhaps to reduce the number of drops that she was taking. We performed the micropulse trabeculoplasty with the IQ532 in the left eye initially. Prior to treatment that day, pressures were 16 on each side. I pre-treated her with Alphagan to prevent a pressure spike after treatment. On continuous wave setting, I placed 4 spots as test burns, titrating the power from 500 up to 700 milliwatts, at which point I saw a blanch. The IQ was then changed to the micropulse setting on a 15% duty cycle. Again, 300 micron, 300 milliseconds. Now, if we assume that Schlemm's canal is 36 millimeters, divide by our 300 micron spot size, we should be placing 120 contiguous spots, which is what we did here to cover 360 degrees. Here's a laser of me, a video of me shaking terribly. Sorry about that. Apparently too much caffeine that morning. So 2 weeks after that treatment, the patient was actually using her drops appropriately, and her pressure was 13 on both sides, although it subsequently rose to 18 on her untreated right eye. Visual acuity was unchanged, and I actually saw her a bunch of times over the next few months because in addition to the micropulse treatment on each side, she had cataract surgery on the right side. Since the laser, she's been stable at 11 or 12 on both sides, and at the 6 months visit, I asked her to eliminate the dorzolamide and just use timolol in the morning and Zalatan at bedtime. So as I mentioned in the introduction to that case, I'd like to be able to give patients a choice between laser or medical treatment. In settings where I've only had access to an argon laser, I was a lot less likely to offer laser initially because of the potential complications and the lack of repeatability, as well as the technical difficulty because of the smaller ALT spot size. SLT and micropulse both appear to offer advantages in terms of complications, repeatability, and technical ease, and are superior to argon, in my opinion, because there's little to no thermal tissue damage. So when it came time to consider a laser for my new solo practice, I considered both of those options. Micropulse with the 532 had a couple of advantages. Clinically, its thermal effects might be even more confined to target tissues than SLT because of the micropulse technology, but the business considerations really made it a no-brainer. A used SLT is $37,000, so more than a new IQ532. And it can only do SLT, whereas with the IQ532, I can perform all those things that I listed earlier in that big list. With an SLT, you got to either send your patients out to somebody else or purchase a separate argon-type laser. So it's great for retinal issues as well. I've used it in continuous wave mode to place barrier laser and in micropulse mode for focal and grid treatment of macular edema. Recently, I had a patient that I performed pan-retinal micropulse phototherapy on. I don't like to call it pan-retinal photocoagulation with this because we're not photocoagulating anything. There's no burns. The benefits are just that. There are no burns, and that a greater area of retina is treated. With standard PRP, you're making burns, so you have to leave areas in between your spots to preserve good vision, whereas with Micropulse, you're treating the entire retina. Also, you don't have to worry about bad things happening. I remember as a resident doing your first couple of laser cases, having your attending standing over your shoulder, and you can practically hear his heartbeat and feel his blood pressure rising as he's worried that you're about to zap the fovea. With the right settings with Micropulse, you don't have to worry about that. So I saw a 62-year-old Caucasian woman who had a branch vein occlusion on the right side in the past with subsequent proliferative retinopathy and several episodes of vitreous hemorrhage, for which she had standard PRP 3 times in the past. She came in to me with a complaint of blurry vision on the right side for the last 3 to 4 weeks. Vision was 20/30 on the right, 20/40 on the left. Pressures were normal at 17 on both sides, and confrontational fields showed an inferior nasal defect on the right eye consistent with her previous BRVO. On dilated exam, she was found to have light to moderate vitreous hemorrhage, dispersed, and some small areas superiorly of denser vitreous hemorrhage. She had an epiretinal membrane in the right eye and scattered PRP scars. We decided to wait a few weeks, redilate, and pending a good view of the fundus, apply panretinal micropulse phototherapy. And here we are applying the laser. You can sort of see over there some blanched areas where I applied test burns. Oh. So I placed test burns using continuous wave, 2 spots at 100 milliseconds, 200 microns, 200 milliwatts, and I achieved blanching of the retina, same as in typical PRP. It was then turned to a 5% duty cycle at 200 milliseconds, 200 microns, and 400 milliwatts, and fill-in therapy was performed in confluent fashion. Okay, so in September of 2013, there was an issue of Ophthalmology Times with an opinion piece on subthreshold laser. The most important thought in that article, I think, is summed up here. The idea that subthreshold laser treatment may not cause substantial or permanent structural changes in the retina is attractive. The rest, when I was a resident, probably the most important thing that I learned when learning how to read a journal article was to look at who was writing the article and why, and to look at the actual language of whatever statements or conclusions were made. So I read this a few times and I realized that the language is actually pretty smart if you had an interest in pharmacologic therapies. Not smart in the sense that it provides a logical argument against Micropulse. It doesn't. It's more like a political advertisement where it creates a negative feeling about the Micropulse without ever linking any negative ideas or providing any proof behind anything. And it doesn't distinguish between the various types of subthreshold treatments. So let's go through a couple of the statements here. The benefit of focal grid laser treatment for diabetic macular edema is not as great or rapid as with anti-VEGF injections. Okay, maybe, but this is talking about traditional, not specifically subthreshold, and certainly not specifically Micropulse. And it also doesn't mention that there are going to be patients that don't respond to anti-VEGF and do respond to Micropulse laser. Number 2, patients can achieve significant gains in vision and reductions in central subfield thickness over time and without substantive visual sequelae from laser treatment. So it's a little unclear here whether this is referring to traditional subthreshold laser, but when I read it, it sounds to me like the implication is that standard laser is good enough, so why use Micropulse? I agree with the part about the gains in vision and reductions in central subfield thickness, but the part about substantive visual sequelae from laser treatment, when I do standard laser, I let patients know about potential decreased contrast sensitivity. And to me, that's important, that's substantive. When custom laser vision correction came out, I'm pretty sure one of the arguments for it was that we could improve contrast sensitivity and not decrease it. And what about the push towards better IOLs and towards laser treatment, laser cataract surgery? When it comes to these things, we're arguing that minute things, contrast sensitivity, that little details like our incisions and our rexus being precise down to the micron, that these are super important, that they're important enough for the patient to pay out of pocket for them. But when it comes to permanently damaging the retina with a traditional laser, creating burns and scars that can't be healed, it's all of a sudden not substantive. To me, it is. Remember, first, do no harm. There has also been relatively few randomized trials investigating this technique for treatment of diabetic macular edema. Define few. I did a PubMed search and I found articles dating back to 1997 with an issue of Ophthalmology, an article by Greiberg and Karatza entitled "The Treatment of Macular Disease Using a Micropulse and Continuous Wave 810 nanometer Diode Laser." That wasn't a randomized study, but it was a good study with good results supporting the use of Micropulse. And it was just the first I found, not the last, not by a long shot. Why aren't there more? Iridex is a well-established, well-respected company, but it's not a pharmaceutical giant with billions of dollars of profit every year. They can't buy a laser for a bunch of doctors, then pay the doctors to do the studies, and then pay the patients to be in the studies. It just can't happen. The reality is that several very important studies have been done on Micropulse, but they've been done by motivated doctors who are most interested in giving their patients the best care possible and have taken upon themselves to advance our knowledge. Here is a not so brief list of some of those articles. Here's one of those articles. This is showing modified EDTRS with a standard laser on the left with microperimetry, fundus autofluorescence, and OCT, and micropulse laser treatment on the right-hand side. And what we see is that there's improvement on both sides, but on that left side, we see permanent damage has been done to the retina. And this was published in Retina back in 2010. Here's some more studies. All right. The subthreshold laser treatment also has some practical limitations. It is difficult to tell where treatment was performed and therefore difficult to assess treatment adequacy, location, efficacy, or retreatment areas. Actually, I find various micropulse procedures to be some of the easiest to perform. It's really not difficult to tell where treatment was performed, neither during nor after the procedure. During the procedure, I keep my eyeballs open. Signals are sent to my visual cortex and from there to my prefrontal lobe. It hangs on to the information and lets me perform the procedure. Afterwards, I document where I've performed the procedure. That way, I or anybody else looking at the medical record knows where we did it. Now, if you're talking about where individual spots are located during the procedure and you're worried about reshooting the same spots, don't, unless you're hovering over the same spot, shooting the exact same spot multiple times on a high repeat rate. You really don't have to worry about shooting the same spot more than once. You're still not going to create a burn. If you shoot a spot and then 3 minutes later end up shooting the same spot, it doesn't matter. You may not have gained anything with that extra spot, but you also haven't caused any harm. As far as adequacy and efficacy, it's really no different than anti-VEGF or standard laser. You're not going to know until you see the patient in follow-up. It's the same. What is different is that anytime you're performing a standard laser, you're harming the retina. And anytime you enter the eye, even if it's just an injection, even if it's with the best technique, there's a risk that something bad is going to happen, really bad. And given the choice between a needle in the eye, with the risk that that entails, or a micropulse procedure with 15 years of study behind it, and that I have a hard time even coming up with risks to list on a consent form when I do these on my patients, a lot of patients are going to choose Micropulse. Frankly, just as with cataract surgery, we're now obliged to let patients know about premium lenses, even if you're not somebody who does premium lenses. I think you're obliged to let patients know that Micropulse is a treatment option, even if you're not somebody who does Micropulse. Take-home messages. Basically, the 532 is versatile with at least a dozen uses that I can think of. It's cost-effective, it generates greater income for your practice while simultaneously decreasing your patients' out-of-pocket expenses, and it even decreases total healthcare dollars. It makes procedures such as trabeculoplasty, focal laser, and panretinal laser technically easier to perform while also being safer for your patients. Thank you.
Dr. Dickman. Be happy to pass the mic around. I'll pass the mic over to you so everyone can hear.
Oh, thanks.
Put that on, you can hear as well. And do you hear me okay?
No,
Do you hear me now?
sort of.
Okay. Excuse me.
How can we titrate the power for the patient because we can't see the burns?
So if you're going to do that, if you're going to titrate the power, you do it on continuous wave settings, okay? Iridex actually has a very nice website that has some of those settings on it. It has some case reports and other things on it that are helpful with getting those settings. And then you convert that over to your micropulse after you've gotten the burn. Now the truth is, when I first started doing the micropulse treatments, I did that. Now, sometimes I do, sometimes I don't. For trabeculoplasty, I don't. I basically go to 1,000 milliwatts, and depending on the particular patient, I may go down from there, but I don't bother to do I don't bother to try to blanch first with continuous wave.
If you're treating a retinal tear,
Yes.
do you get adequate chorioretinal adhesion with this laser, even though you get no visible scars?
If I'm treating a retinal tear, I put it on continuous wave. So that's one of the good things about the laser, is that you can do all these procedures. You're not obliged to use it in micropulse mode. We can still do traditional procedures with it on patients that we didn't want to do traditional procedures. When micropulse is the procedure of choice for that particular patient, you put it on micropulse. But for retinal tears, definitely continuous wave, same as you normally do.
Yeah, thank you very much for the presentation. I have been doing micropulse, but I've been using the 810, nanometer Optos laser.
Mm-hmm.
And I do a lot of micropulse diode laser trabeculoplasties or MDLTs. I'm interested to know, my problem, of course, has always been that the results I get from my patients have not been too consistent over a period of time. Because I sometimes get drops of between 2 to 8 millimeters of mercury immediately after the treatment. I hardly get any spikes. But then over maybe 3-6 months, pressures tend to creep up to pre-treatment levels. And I tuned into a webinar that you did some time ago on green laser and found out that the speakers tended to say that the results were more consistent. Can you comment on that, particularly with regards to comparing results you get with the 810 and the 532?
I've never actually used the 810, so I don't know that I can intelligently answer that for you, unfortunately.
I can talk to you about that. Stay afterwards.
Sorry.
We have another question over here.
How does neovascularization and proliferative diabetic retinopathy regress with micropulse PRP if there's no destruction of the retina?
Because the regression isn't from destroying the retina, it's from upregulation of those biochemical factors. Let me see if I can get back to that slide here for you. And the idea is that even with traditional PRP, the benefit isn't really from the retina that you're killing, it's the surrounding areas on the edge of your treatment, on the edge of that burn, that are upregulating these factors and causing the regression. So that when we do the micropulse, because you don't have that burn, you actually have a larger area that's contributing to the beneficial effect. Here we go. So that would be these two slides. So with the continuous wave laser, you're burning that central area, and it's that shaded area surrounding it that's actually contributing to the regression of the retinopathy. Whereas with the micropulse, it's the entire area. So you're treating a larger area with the micropulse. It's a confluent treatment, but that means that that entire area that you're treating is contributing to the benefit.
If you get a positive pressure reduction,
A positive what? Sorry.
pressure reduction from doing your trabecular meshwork treatment, how long is the average duration of the positive effect?
It's a good question. I've only had it since January of 2012, the laser. I haven't seen anybody lose efficacy over that period of time. Generally, I quote patients the older studies. I tell my patients that it works in 80% of people and it's going to last 5 years in 49% of patients, and that if it worked the first time, it's probably repeatable. Okay, but so far, nobody that I've treated, I haven't lost any effect.
Do you get incremental improvement in vision by using things like latanoprost or other medications after using the MLT?
I'm sorry, say that again?
Do you get any further improvement by using the anti-glaucoma medications, having this procedure done on your trabeculum?
Sure, it's certainly not in either or. I don't either use Micropulse or use medications. I have plenty of patients where they need both. If somebody comes into my office and their pressure is 28, I usually say to them, hey, let's get you on Xalatan or whatever it happens to be. And then we'll do the Micropulse and we'll see what your pressures are. You may need to stay on the Xalatan, or maybe the Micropulse will give you enough. It really just depends on the pressure, but it's definitely not an either or situation.
Great. Any other questions, thoughts, comments? Okay, well, thank you all for attending.
Thank
and
you
your
very
time.
much.
Thank you, Dr. Dickman.